I'm Dr. Fakir Rabari, and this is community-acquired pneumonia in adults. Respiratory tract infections can be divided to upper respiratory tract infections and lower respiratory tract infections. Common cold, which is the most common upper respiratory tract infection, primarily affects the nasal cavity and the sinus area. Otitis, which is basically the infection of the ear, is also considered an upper respiratory tract infection. You can also have pharyngitis, which is the infection of the pharynx. Pharynx is, of course, the canal that connects the nose to the throat. And lastly, you can have rhinosinusitis, which is primarily the infection of the sinus cavity. We can also have lower respiratory tract infections. There is something called bronchitis. There is the left bronchus and the right bronchus that connect the trachea to the two lungs, and the inflammation of the bronchi will lead to bronchitis. And then there's influenza and pneumonia that can cause infection deeper into the lungs, leading to problems with oxygenation. And of course, you can have pulmonary tuberculosis, which we will discuss later. Now, let's take a look at pneumonia. Pneumonia is a form of acute respiratory tract infection that affects the lungs. When an individual has pneumonia, the alveoli in the lungs are filled with pus and fluid, which makes breathing painful and limits oxygen intake. In 1901, Sir William Osler noted in the 4th edition of his book, The Principles and Practice of Medicine, that the most widespread and fatal of all acute diseases, pneumonia, is now captain of the men of death. Over a century later, the prominence of pneumonia as a clinical entity remains. In fact, it remains among the top 10 most common causes of death, and it is the single most common cause of infection-related mortality. Now, let's take a look at the anatomy of the lungs. As you can see, there are two zones in the lungs. There is the conducting zone and there's the respiratory zone. The conducting zone basically consists of trachea, bronchi, and bronchioles. As you can see, as we go deeper into the lung, the number of branches increase. So when you get to the alveolar sacs, there is an extreme number of sacs, which is intended to increase the surface area in order to allow oxygenation of the blood. Now, when there's inflammation in the conducting zone, such as bronchitis, it becomes difficult because this area is inflamed, it becomes difficult for the air to go through, so it will be difficult and painful for the patient to breathe. Now, when we have a more severe infection such as pneumonia, there will be deeper into the respiratory zone. So now the patient will have respiratory issues. So there will be marked hypoxia in the patient. Now let's analyze the lung on a cellular level. Now I'd like to bring your attention to the structure of alveolar. So note that in the alveoli, there are type 1 epithelial cells and type 2 epithelial cells. And type 2 epithelial cells actually secrete surfactant, and surfactant has a crucial role in maintaining alveolar structure by reducing surface tension. And the reason it is important to know that these type 2 epithelial cells secrete surfactant is that surfactant can actually affect antibiotics. The most important antibiotic that's affected by surfactant is daptomycin. Daptomycin is completely deactivated by surfactant. So while daptomycin is an excellent antibiotic for treatment of MRSA infections, it should never be used for respiratory tract infections because by the time daptomycin gets to the alveoli, it will be deactivated by surfactant. So you should never ever use daptomycin for pneumonia. Now, vancomycin, linezolid, and ceftaroline are not affected by surfactant, and they are used for treatment of MRSA pneumonia. Now let's take a look at the pathophysiology of pneumonia. As I mentioned, there are two zones in the lower respiratory tract. There's the conducting zone and there's the respiratory zone, which is basically the lung parenchyma. Now the lung has a elaborate system of host defenses that when functioning properly, they actually are very effective in protecting against pathogen invasion of the lungs. Now, for the most part, infections in lower respiratory tract occurs in patients with impaired host defenses, usually due to genetic disorders or in compromised ciliary functions such as patients who smoke. Now let's take a look at the normal microbiota in the airways. Lungs have traditionally been considered sterile in a healthy individual. However, recent studies documented that healthy lungs contain diverse communities of bacteria, mostly of oropharyngeal origin, that are viable, are metabolically active, and contribute to the host's dynamic calibration of immune defenses. In general, you can see in this picture that the upper respiratory tract exhibits a relatively high biomass. So you can see the oral cavity and essentially the oropharyngeal areas of the lung have a lot of organisms present. That what you see in the blue box is what's normally present in a healthy individual. By contrast, the lower respiratory tract exhibits a relatively low biomass consisting mostly of oral commensals. Several factors can contribute to dysbiosis changes along the respiratory tract, as you can see in the red boxes. So these red boxes, what's listed there, can result in imbalance of the bacteria that reside in these sections. Aspiration of oropharyngeal or gastroesophageal content is the predominant means by which bacteria reach the lower airways, as you can see by the arrows. So from the oral cavity they go down into the trachea, and also gastric content can go up and into the tracheal regions. And of course, there are three major lung clearance mechanisms, such as coughing, mucociliary transport, and the innate immune system that keeps the bacteria relatively low in the lungs. And that explains why certain individuals are at higher risk of developing lower respiratory tract infections. It is important to note that all individuals are at risk for development of pneumonia. Now, some individuals have higher risk of getting pneumonia. There are different ways of getting pneumonia. Inhalation is the most common route. Inhalation of infectious particle is the primary route that leads to development of pneumonia. Aspiration of oral flora can also lead to pneumonia, which we call aspiration pneumonia. Now note that this typically includes the flora in the mouth and possibly what's in the gastric content, but it's unlikely to include anything from the, anything past the stomach. So it's unlikely to include anything from the intestine. So Bacteroides are extremely unlikely. There are also other possibilities of getting pneumonia. For example, if someone has bloodstream infection, because the blood goes to the lung where oxygen exchange occurs, that infected blood can actually infect pneumonia. You can also get pneumonia from invasive procedures such as intubation. Now, while these are possibilities, they are not as common. So the most common route of getting pneumonia is by inhalation. Now let's take a look at chest radiograph, also known as chest X-ray. Now, when we look at the film in a normal chest radiograph, it's supposed to be clear. So generally speaking, it's clear. The lungs are clear. You can you can see the heart, and you can see the diaphragm. Now, when there are things in the lung, what we see on the film is increased opacity, which we call infiltrate. Now, these infiltrates or increased opacities, which you will see in chest X-rays B and C, that could be due to different things. Some of the possibilities include water in the lung, which could be, so if you see water on the chest X-ray as infiltrate, it would be common in patients with heart failure who have fluid retention, patients with low albumin, for example. Cirrhotic patients also have fluid retention, so you will see these fluids infiltrate on chest x-ray. The content can also be pus, which will be the case in pneumonia. So if the patient has pneumonia and there's pus in the lungs, you will see infiltrate on the chest x-ray. There could also be blood, which is the case in trauma. So if somebody has ruptured their lungs, there will be blood in the lungs, which will show as infiltrate. And of course, the infiltrates could be cells, which will be the case in cancer. So if there are cancer cells in the lungs, they will show as infiltrates. Now, there are different ways of describing infiltrates. Two of the common ones that you will encounter are patchy infiltrates and dense consolidation. So when, patchy infiltrate could be usually due to either presence of fluids or viral infections or atypical organisms. And when you have dense consolidation, as you can see in film C, dense consolidation is usually more likely to be due to non-atypical organisms such as gram-positive and gram-negative organisms. Now keep in mind that the chest radiograph is just a tool to help with diagnosis. There's no way to know for sure what's causing the infiltrates. It's important to use chest x-ray with clinical judgment. Another thing that can show up as infiltrate is atelectasis, which is basically the collapse of areas of the lung. So that's also something that you will see frequently. Now let's take a look at reliable resources for lower respiratory tract infection. Infectious Diseases Society of America and the American Thoracic Society developed most of the guidelines for lower respiratory tract infection. The first guideline is the 2005 ATS-IDSA guidelines for the management of adults with hospital-acquired ventilator-associated and healthcare-associated pneumonia. This guideline is particularly useful if you need information about healthcare-associated pneumonia. There's also the 2007 IDSA ATS guidelines on the management of community-acquired pneumonia in adults. Now, there was a 2009 IDSA guidelines for seasonal influenza in adults and children, but this guideline is no longer used because it's outdated. Instead, we use the 2011 CDC guidelines for antiviral agents for the treatment and chemoprophylaxis of influenza. There's also the 2016 IDSA ATS guidelines for management of adults with hospital-acquired and ventilator-associated pneumonia. There is also the 2018 IDSA guidelines on seasonal influenza that was recently published. Now, in October of 2019, after 12 long years, IDSA and AST together developed updated guidelines for community-acquired pneumonia, which borrows some components from the 2007 guidelines. We will discuss those shortly. The first learning objective is describe the pharmacokinetic and pharmacodynamic properties of antibiotics used for pneumonia. Let's review what pharmacokinetics means. Traditionally, pharmacokinetics is known as what the body does to the drug. It basically involves ADME, absorption, distribution, metabolism, and elimination. It's important to consider absorption so we know the bioavailability of drugs. When it comes to distribution, it's important to know protein binding. So for example, some patients may have low albumin. Albumin is the #1 protein that binds antibiotics. When it comes to metabolism, it is important to know if specifically a drug is metabolized with the CYP enzyme. That could include drug interactions. And of course, when it comes to elimination, it's important to consider renal, biliary, and fecal clearance. Now, when we say clinical pharmacokinetics, we basically mean application of these pharmacokinetic principles to safe and effective therapeutic management of drugs in individual patients. And the goal is enhancing efficacy while decreasing toxicity. What about pharmacodynamics? Pharmacodynamics is actually what the drug does to the body. In the case of antimicrobials, the body refers to the pathogen. So we don't really want the drug to do anything to the human body. So once a drug is given to a patient, the body will handle the drug. So there will be absorption, distribution, and elimination. So this is the pharmacokinetic properties. And then there will be concentration in the body fluids and also at the site of infection. And then at the site of infection is when you want the drug to do something to the pathogens, and that would be the pharmacodynamic outcomes, which we refer to as PK/PD. And of course, there are things that antibiotics do to the body, and those are referred to as toxicodynamics. These are the things that we don't really want antibiotics to do to the body. Here are some important parameters to know. On the horizontal axis, we're looking at time, and on the vertical axis, we're looking at concentration of drug. So once a drug is given, at the end of infusion, you get the maximum concentration, and that's referred to as peak or Cmax. And then once we stop the infusion, the body starts to clear it. So the concentration goes down until it's time for the next dose. At that time, we have the minimum concentration or trough, also referred to as Cmin. And then the next dose is given and the drug goes up. And then at the end of infusion, the body starts to clear. There's also the concept of area under the curve, which is all the shaded area here, for a 24-hour period. So it doesn't matter how frequently you give the dose, the AUC is often from time 0 to 24 hours. So if this drug was given once a day, you would only have one of these over 24 hours. Also, if this drug was given every 8 hours, then you would have 3 of these peaks. But regardless, AUC is the area under the curve for a 24-hour period. And of course, you could get the level at any time between peak and trough, and that would be considered a random level. Now, when it comes to antibiotic, these things only tell you how the body is handling the drug. So whether it's AUC or the peak or the trough, it's basically telling you how much drug is left in the body at a specific time. It doesn't necessarily tell you anything about the pharmacodynamics of the drug, because it doesn't really tell you anything about the organism, and we need to know something about the organism. And what we need to know about the organism is the MIC, or the minimum inhibitory concentration. We can combine these pharmacokinetic parameters with MIC to get PK/PD indices. So the 3 commonly used are the peak to MIC ratio, the AUC to MIC ratio, or the time above MIC. So when the concentration goes above this MIC concentration, it will go above and then eventually will go down and then go below the MIC. The time it takes to go above the MIC and then below the MIC, that's referred to as time above MIC. In this picture, on the horizontal axis, we're looking at time, and the units of time are hour. And on the vertical axis, we're looking at in the log drop in the CFU, or colony forming units of bacterial growth. So CFUs are basically units of measuring how much bacteria grow on culture. So in all 3 of these experiments, we have the control. So the red circles are control, meaning that if we don't use any antibiotics, we just let the organism grow. So as time goes on, bacteria grow in the absence of antibiotics. Now the question is, if we start to introduce antibiotics, how much does it prevent growth of bacteria? MIC is the minimum inhibitory concentration of a specific antibiotic for a specific organism. So in these experiments, we're giving antibiotics in increasing concentration and see how much increasing the concentration affect the growth. So for example, on the left hand side, we're looking at the antibiotic tobramycin. So if we give a quarter of the MIC, as time goes on, you can see that the growth of bacteria slows down but doesn't completely prohibit it. Now if we gave exactly at MIC concentration, as you can see that as the time goes on, bacteria start to die. So the colony forming units start to drop. Now at higher concentration, so for example at 4 MICs, you can see that bacterial growth actually drops faster, and as we increase the concentration, this drop in growth of bacteria becomes larger and larger. This suggests that tobramycin has concentration dependent killing, meaning that the more of a concentration of tobramycin that we use, the more the growth of this organism was dropped. Now let's look at ciprofloxacin. Ciprofloxacin, they did the same experiment. So you can see that as they increased the concentration of ciprofloxacin, more and more of the organism died as time went on. Now compare that to ticarcillin, which is a beta-lactam. Now as they increase the concentration of this beta-lactam, you can see that the organism dropped, but at some point, increasing the concentration didn't make a difference anymore. So for example, once we reach a concentration 4 times the MIC, we got the maximum amount of killing. So 16 times the MIC in negligible amounts. In fact, a concentration 24 times the MIC made no difference compared to 16 times MIC. And this suggests that beta-lactams do not have concentration-dependent killing, whereas tobramycin, which is an aminoglycoside, and ciprofloxacin, which is a fluoroquinolone, these two show concentration-dependent killing because at the highest concentration of these antibiotics resulted in the most amount of killing. So generally speaking, antibiotics can be divided into concentration-dependent and concentration-independent killing. Now, we're looking at the evolution of PK/PD. So as time went on, then clinicians started to refer to concentration-dependent as time-dependent. So we had concentration-dependent and then we had time-dependent. And as I showed you the examples of fluoroquinolones and aminoglycosides, those are concentration-dependent. And then the time-dependent would be the beta-lactams as well as vancomycin. And the PK/PD parameter for time-dependent, specifically for beta-lactam, is the time above MIC. So it's not necessarily the concentration of beta-lactams, it's more of how long the concentration is above the MIC that would result in maximum killing of organisms. Now compare that to concentration-dependent. So if you have a high concentration, the ratio of peak concentration to MIC, the higher this concentration will result to the maximum amount of killing. And then there's the concept of AUC, or area under the curve, to MIC ratio, which is used for aminoglycosides and fluoroquinolones, which I will explain more. But this AUC to MIC is also used for vancomycin. So generally speaking, peak to MIC ratio is used for concentration dependent, and time above MIC is used for time dependent. And then AUC to MIC, it just depends. For some antibiotics, AUC to MIC means concentration dependent, and for some antibiotics such as vancomycin, it just means time dependent. Now here you can see that the PK/PD target for beta-lactams is time above MIC. For carbapenem specifically, you need time above MIC for at least 40% of the dosing interval to get bactericidal activity, whereas for cephalosporins, at least 60% of the dosing interval is required. For penicillins, is 50% time above MIC. Now it is also alternatively proposed that time above MIC is best to be increased to 100% of the time, especially in critically ill patients, in order to maximize the efficacy of these beta-lactams. For fluoroquinolones, you can see that the PK/PD target is AUC to MIC. For majority of the data is with gram-negative, so it's proposed an AUC to MIC ratio of more than 125 to 250 is required for gram-negative activity. For gram-positive, a lower target of at least 30 is proposed. In this picture, we're looking at the bacterial 70S ribosome, which consists of the 50S subunit and the 30S subunit. The 50S subunit and the 30S subunit will come together around the mRNA or messenger RNA in the bacteria, and tRNAs will actually carry an amino acid and bring it to the ribosome in order to start the translation process. Generally speaking, translation consists of initiation, elongation, and termination steps. Some of the antibiotics that are important to know are clindamycin, linezolid, and macrolides, which all of which bind in the 50S ribosome, and they block the peptide bond formation between the different amino acids. As a result, protein synthesis will be inhibited. Other antibiotics that are important are also tetracyclines and aminoglycosides, will bind to the 30S subunit and will also inhibit protein synthesis. So as you can see, aminoglycosides and tetracyclines will basically compete for the same site, which is the 30S, whereas clindamycin, linezolid, and macrolides basically compete for the same site in the 50S subunit. I have summarized some of the key pharmacokinetic, pharmacodynamic properties of these antibiotics in this table that you should review. Pay close attention to the adverse effects of these antibiotics. Aminoglycosides, for example, can cause nephrotoxicity, which is typically reversible. They can also cause ototoxicity, which is usually irreversible. And they can also rarely cause neuromuscular blockade. Keep in mind that aminoglycosides are not orally available, whereas the rest of these antibiotics listed in this table are orally available. These oral agents can cause gastrointestinal upset. They are also available as IV formulation. One thing that's important to know about tetracyclines is that they can cause photosensitivity, so that's an important counseling point for the patients. So they should avoid, exposure to the sun or tanning beds. It can also lead to deposition in bone and teeth, which is important in growing children. The major adverse effect of clindamycin is diarrhea, and clindamycin is actually associated with Clostridioides difficile infections. Macrolides are associated with QTc prolongation, so it's important to check EKG before starting someone on a macrolide. And linezolid has an adverse effect profile that's exposure dependent. So the more a patient is exposed to linezolid, the more adverse effects will occur. Now, generally speaking, linezolid leads to GI upset, headache, and occasionally can cause a serotonin syndrome, especially if it's used in combination with SSRIs. And within the first 2 weeks, you can also experience lactic acidosis. Now, beyond 2 weeks, patients may also experience bone marrow suppression. So this could be a drop in, white blood cells, so neutropenia. It can lead to drop in red blood cells, so anemia can happen beyond 2 weeks. Now, beyond 4 weeks, that's when neuropathy can happen, and rarely optic neuritis. Now, fluoroquinolones have a unique mechanism of action. They actually bind to topoisomerase 2 and 4. Therefore, they inhibit DNA synthesis in bacteria. Fluoroquinolones can cause neurotoxicity and tendonitis, which actually happens to be a black box warning. Vancomycin binds to diallo or D-alanine, which inhibits peptidoglycan synthesis. Peptidoglycan is a component of the cell wall in bacteria. Common adverse effects of vancomycin is red man syndrome, which is actually, we can actually avoid that by prolonging the infusion time of vancomycin. And of course, vancomycin is nephrotoxic. Beta-lactams, such as penicillins, cephalosporins, carbapenems, and aztreonam, are available, most of them as IV, but many penicillins and cephalosporins are also available as PO. Carbapenems and aztreonam are strictly available as IV with no PO formulation available. Generally speaking, beta-lactams cause GI upset, hypersensitivity. So a penicillin allergy is the most common drug allergy that you will see in patients. They can cause skin reactions such as rash. In high doses, beta-lactams can cause seizures. And also occasionally beta-lactams can cause drug fever. So while we usually think of infections when a patient has fever, occasionally a beta-lactam itself can cause a fever, which we refer to as drug fever. And we also can have beta-lactams in combination with beta-lactamase inhibitors. Now let's take a look at pharmacodynamics of beta-lactams. Let's use cefepime as an example. So let's say you're infusing cefepime 1 gram every 12 hours. So you give this twice a day. And what happens is that because every time we give a dose, the amount of time that this concentration goes above MIC is about 4 hours. So overall, over a 24-hour period, you have 4 hours here and 4 hours here. So overall, you have 8 hours out of 24. So the time above MIC for 1 gram Q 12 hours of cefepime is about 33%. Now, what happens if we double the dose? Instead of 1 gram Q12, we do 2 gram Q 12 hours. And you can see that you get a much larger peak. However, that doesn't necessarily translate to double the time above MIC. So what happens is that instead of 4 hours above MIC, you get 6 hours time above MIC for each dose. So overall, it's about 12 hours out of 24, which translates into 50% time above MIC. So by doubling the dose, we increase time above MIC. Now, what if instead of increasing the dose, we increase the frequency. So every 12 hours, we actually infuse this every 8 hours. So what happens is that you actually get 3 peaks. And because you now have 3 of those 4 hours, so you get 12 hours out of 24. So that's 50% time above MIC. So essentially, by giving 1 gram every 8 hours, we achieve the same 50% time above MIC as doubling the dose. So from a pharmacodynamic standpoint, it's equivalent. The advantage of increasing the frequency instead of doubling the dose or increasing the dose is that overall throughout the day you give less of the drug. So 2 gram Q12 will end up with 4 grams over a 24-hour period. With 1 gram every 8 hours, you end up with 3 grams every 24 hours. So that has, from a toxicodynamic perspective, is less likely to cause toxicity because we give less of the drug. Yet from a pharmacodynamic perspective, we achieve the same time above MIC. Now, another thing that we can do is to extend the infusion time. So normally cefepime is dosed over a 30-minute period, which gives you that 4-hour time above MIC for each dose. And if we were to infuse this instead over a 3-hour period, so it actually increases the time above MIC without increasing the dose or the frequency. And ultimately, we can do continuous infusion. So basically, the entire daily dose can be infused over 24 hours. And what happens is that once the concentration goes above MIC, because we never stop the infusion, it continues to stay above MIC, and that's how we get time above MIC of 100% of the dosing interval.